The work that I do is, over the last 20 years or so, is really looking at the psychological processes that underpin suicide and self-harm. And in this particular project, which is funded by MQ, what we're hoping to do is a really innovative study in which we look at an intervention, a psychosocial intervention, which is developed in the United States, and try and tailor it and test it in a UK population. I've always been passionate about trying to prevent suicide and managing and understanding the psychological processes that underpin the risk of self-harm and suicide. And so when I got involved in this area, I had no direct experience of people losing a loved one to suicide. But sadly, in the course of my career, the person who brought me into the field of suicide and self-harm has taken his own life. And a very, very close friend of mine, a colleague and a really, really close friend, she has taken her life. So it's just redoubled my efforts, redoubled my enthusiasm, but it also has highlighted the scale of the challenge that we face. Now, there is some growing evidence for psychological treatments to reduce the likelihood that people who are suicidal attempt suicide again, or people who self-harm will self-harm again. Now, what we're looking at and what we're hoping to do is demonstrate that a particular brief psychological intervention, which has been developed in the United States, called safety planning. So it's safety planning with telephone support. What we're hoping to do is demonstrate that that intervention is feasible and acceptable for people who are suicidal. Now, the reason that intervention is really important is because what we try and do in this intervention is to get people to identify warning signs or triggers to their suicidal crisis, so that the next time they become suicidal, instead of attempting suicide, they hopefully are kept safe. And that's what we hope will be the impact, is that we reduce the likelihood that people who are suicidal make that transition from thinking about suicide to actually attempting suicide. The stark reality is that most people who develop mental health problems will develop them first in either adolescent or young adulthood. So it's absolutely fundamentally important that we intervene early and ensure that there's treatments and support available for young people at an early stage. In the context of self-harm or suicide work, my specialty, we know that upwards of 20% of young girls by the age of 16 will have self-harmed. We know that self-harm is one of the strongest predictors of suicide in the future. So again, we need to ensure that the people who are at risk, in this context, looking at adolescent self-harm or self-harm in early adulthood, that we intervene early to ensure that there's support and treatment there. Because we need to deal with this barrier, the stigma associated with mental health problems, so that more people receive treatment and support earlier to reduce the likelihood that future generations have this distress and this unbearable context of, I'm experiencing emotional problems and I'm frightened to seek help. In terms of the sort of ambitions for the research that we do, if you look on a global scale, at least 800,000 people die by suicide each year. Suicide is the leading cause of death amongst young and middle-aged individuals in many, many countries, including the UK. So our work can do something, anything, to save a single life, I think is worthwhile. There's two big challenges at least. There are many challenges, obviously, but there's two that come to mind. One is the funding landscape. Everybody knows, sadly, that the funding for mental health science is just not there. And it's great to see MQ leading the charge now to really raise a profile with respect to this is an important topic. But really to ensure that we get that funding, that it becomes a priority. And then secondly is to ensure that that mental health science is translated into action, translated into treatment, translated into access to services. And to translate these into access into services, we need to ensure that the resources are there, obviously, more broadly in a clinical and public health context, but we also need to challenge stigma so that people who are worried, people who are experiencing mental health problems seek help.